Carey, I think you have an announcement to make.
I do, my lady. Professor Helen Snooks was due to give evidence today, but unfortunately, over the weekend, she fell and has sustained a concussion and requires surgery for a wrist fracture, which is likely to take place either today or imminently. Understandably, therefore, she's not currently fit to give evidence. The inquiry intends to seek an update on her progress and indeed her recovery, we hope, and we will update your ladyship and the core participants in due course. Thanks to the efforts of the legal operations team and indeed to the witnesses themselves, a number of this afternoon's witnesses have been brought forward, and so we're very grateful. We will be able to deal with Professor Edwards and then carry on with the timetable as envisaged.
Thank you very much, Carey, and could you ensure that we send to the Professor our best wishes?
We will.
Ms Neild.
My lady, may I please call Professor Adrian Edwards?
I swear by Almighty God that the evidence I shall give shall be the truth, the whole truth, and nothing but the truth.
Professor Edwards, could you give your full name, please?
Adrian Gwynn Conrad Edwards.
Thank you. Professor Edwards, you've been good enough to provide an expert report to the inquiry dealing with general medical practice during the pandemic. Is that right?
Correct.
That report runs to 123 pages and it has been given the INQ number INQ 000474283. You're familiar with that report and I think you have a copy of it in front of you. Is that
correct?
Right? If we could deal, first of all, Professor Edwards, with your professional background. You're a Professor of General Practice at Cardiff University and you have held that role since 2005, is that right?
Correct.
And as part of that role, you have been Director of the Prime Centre Wales. That's a research centre for primary and emergency care, is that correct?
That's correct, and where I collaborate with Professor Snooks.
And you...
Sorry, I missed that, and I think the stenographer may have missed it. We have a new stenographer, Professor, so whereas we've all got used to certain acronyms, dare I say it, the NHS seems to be flooded with acronyms, and also medical expressions. If we could make sure that we speak very slowly and clearly so the stenographers can find their way.
Okay.
Thank you, my lady. I'll make a mental note to do the same. I think you said that you collaborate with Professor Snooks at the Prime Research Centre.
Correct.
You have been Director of the Wales COVID-19 Evidence Centre between 2021 and 2023, is that right?
Correct.
And as Director of the Wales COVID-19 Evidence Centre, you were also a member of the Technical Advisory Group for the Welsh Government, is that right?
Correct.
You're Director of the Health and Care Research Wales Evidence Centre since 2023.
Correct.
And you were a partner in general practice in Gwent between 1999 and the 30th of June 2020, is that right?
Correct.
And you are now working 1 day a week as a salaried GP at a health centre also in Gwent.
Correct.
Thank you. If we could move on, please, to your report. You outline at the beginning of that report the organisation of primary care and general practice services in the UK, and you explain that general practice is just one of 4 components of primary care. Is that right?
Correct, as one of the contractor professions, the others being pharmacy, dentistry and optometry.
So you've described them as a contractor profession. I think it's right that general practitioners are not directly employed by the NHS. Could you explain that, please?
So in the usual traditional model of general practice, the practice, i.e. the partners in that practice, contract with the NHS to provide the general medical services to that population of patients. So the partners own the business and they employ various other staff, nursing staff, other allied health and administrative staff, and say they have a contract to provide the general medical services for the population. The contract is with the NHS.
And we'll come on, if we may, in a little while to talk a little more about the nature of that contract. But you said there that partners employ other staff within the general practice surgery, and you explain in your report that over the last 10 to 15 years, there has increasingly been a multidisciplinary team model.
Yes.
How does that work in general practice?
So first of all, make a comment about the partners themselves. So traditionally, they would have only been general practitioners, but lately there have been other professional members as partners of practices. So in fact, in my own practice, two of the 5 partners, one is an advanced nurse practitioner and one is a mental health practitioner. So they are the partners with 3 GPs. But either way, the partnership will employ a range of staff to provide its services. So they would, again, traditionally have been practice nurses, but then increasingly diversifying that to advanced nurse practitioners, advanced care practitioners, also pharmacists, a range of others, potentially like physiotherapists or others. And then lately, again, particularly staff to assist with the provision of services, healthcare assistants, sometimes maybe called nursing associates. They're not exactly the same, but often providing many of the same roles, assisting the nursing and medical staff. So, for example, taking blood tests, doing ECGs, swabs and infections, etc. So there's this group of the workforce, healthcare assistants and related terms, providing services face-to-face with patients, and then also the administrative staff, increasingly management, and then, of course, the reception and care navigation staff.
You mentioned their care navigation. Is that in order to direct the patient to the right person for their particular issue?
At the right time as well, hopefully, yes. So these people, they might, again, traditionally have been receptionists who've gained additional skills in care navigation. So the role is to assist the doctors and clinical staff in prioritising the patient's need and to the right member of staff at the right time.
So does that require also a degree of training for the care navigator?
Yes, there should be.
If we can come back then to the contractual nature of the relationship between the NHS and the partners of a general practice surgery. Again, you set out in your report that across the UK, all GPs have to provide essential services and may also provide enhanced or additional services. Could you outline very briefly what are those essential services and what are the enhanced services?
So the essential services would be the core business of general practice, seeing patients attending with same-day needs or ongoing needs relating to long-term and continuing conditions, as well as the related nursing, pharmacy, other functions, managing their day-to-day and ongoing care. And that would also include areas around health promotion, for example, and prevention and screening. And then there are the additional or enhanced services, which are additional contracts that a practice signs up for to provide a service. And they can be various in various districts. They can be either locally determined or nationally determined. But they might, for example, include services like providing minor surgery in a practice. If a GP has those skills and is able to provide that service, removing lumps and bumps and doing joint injections and that type of thing. So that might be a service. Another one might, for example, could be very specialist things like substance misuse services. Again, if there's a clinician in the practice who has those skills and training, then they might provide a specific service to patients, service users with problems of substance misuse, who might otherwise have gone to secondary care or other community services, but actually it is helpful and by and large efficient to be providing that service in the local practice.
And would those enhanced services also include things like a quality outcomes framework where it's necessary to conduct, well, perhaps you could explain what the quality outcomes framework.
So the quality outcomes framework has iterated in the different countries across the UK, but in principle, it's to ensure quality, and it's about pay for performance, demonstrating that the practice is reaching quality targets. it has been termed different things in different countries. So in Wales, it became the Quality Assessment and Improvement Framework. And I believe in Scotland, it was actually disinvested. The point about whether it's an additional service, actually not. It was part of the core contract. And when it started, probably best part of 20 years ago, it was a section of the income to practices that was identified as very much connected with achieving those performance targets.
And during the pandemic, did that change that position between the enhanced services that could be offered by a general practice surgery, and additional payment would come in if those services were offered?
Well, I think it would be probably an interesting problem, a difficult problem sometimes, that clearly practices are built around income and expenditure, and those incomes relating to the enhanced services would have been built into the way a practice delivers its services with staff and so on. So some of those services might have been very difficult to deliver in those immediate phases of the pandemic, and that has significant implications in terms of practice income. I believe, on the whole, services were suspended, but with an assurance of income to enable a practice to keep functioning with its complement of staff.
Thank you. You've referred to the slight differences that exist in that contracting model, or the details of those contractual arrangements between the four nations of the UK. But I think you set out in your report that broadly that general practice model is the same across the four countries of the UK. And it might be appropriate to mention now that in preparing your report, when you assessed the data that was coming from a variety of sources and academic studies, sometimes directly comparable data isn't available in each of those four nations. Slightly different data is collected or sometimes not collected.
Correct, yes.
And I think you've noted at a number of places in your report a limitation or lack of data from Northern Ireland in particular.
Yes, I think it's variable according to which issue and metric we might be examining. But yes, on the whole, data were stronger, more comprehensive from NHS England, and then sometimes NHS Wales or NHS Scotland might be particularly strong in a given area, and often I think it was missing from Northern Ireland. Or sometimes data may be available but not published completely. So different participants in this inquiry may have reported different elements of data which may not always be publicly available.
Thank you. I think nevertheless you observe that the similarities in the general practice model across the four nations mean that conclusions that you've reached based, for example, on data from NHS England are going to be applicable to GP services in the other nations of the UK. Is that right, broadly?
I think in general we would be looking for what can be transferable from one setting to another. So studies or analyses would be undertaken. We would, from a research point of view, we would examine whether they're generalizable. Is the exact setting and the participants in that survey, for example, relevant in one setting, some part of England, say? Is it relevant to generalise to other areas of England or Wales, Scotland, Northern Ireland? Sometimes it's not completely generalisable, but nevertheless we're looking for transferable lessons, and I think that's quite a key theme in some of the evidence that we might be examining.
Thank you. Looking at the way GP operates across the UK, you undertake a brief comparison between the UK and other developed countries in the world in terms of the provision of full-time equivalent general practitioners per 100,000 of the population. And you've observed in your report that the UK doesn't compare very well.
Yeah.
I think you've taken the example of Australia, which has 120 full-time equivalent GPs per 100,000 of the population.
Yes, actually, just to check the detail on that, I think that graph is actually head count of GPs, And a later graph in my report, which has some slightly different figures, is about full-time equivalent.
So I think you've also identified that, in fact, increasingly in the UK, GPs are choosing to work part-time. So the full-time equivalent numbers are quite different from the total headcount. Is that correct?
Yes, very much so. We might call it a portfolio career, usually combining other activities, like myself, for example, in a university alongside clinical practice.
And I think data shows that England has just 45 full-time equivalent GPs per 100,000 of the population. Is that right?
Which
I think this is in paragraph 22 of your report, if that assists.
yes, that's right.
I think you note there 120 full-time equivalent GPs in Australia per 100,000. New Zealand had 74 full-time equivalent GPs. Canada, 103 family physicians. Whereas England, as we've said, had 45 full-time equivalent GPs, and that was a decline in 2022 from the figures in 2015, which showed that there were then 52 full-time equivalent GPs in England.
Yes, so there are disparities between these different countries, but many of which have health systems and provision which are in some ways similar to what we would recognise. And so as well as the fact that our provision of GPs and other staff actually have similar figures as well, our provision is lower, and then the trends are also actually very concerning.
Your report also makes mention, this is at paragraph 137 in your report, of the inverse care law and how that applies to general practice. Could you explain what the inverse care law is and how that does apply in general practice in the UK?
Okay. So the inverse care law was a term, a concept, conceptualised in 1971 by an author called Dr. Julian Tudor Hart, who was one of the leading players in Welsh general practice at the time. And it is actually a pun on a concept in physics, which is the inverse square law. However, the inverse care law here states that the provision of good medical or social care services is inversely proportional to the medical need for it in the population. And actually there's a rider on that, which is that the influence of that phenomenon is greatest where market forces are most evident in that healthcare system. So the reality is that populations with the highest medical and social care need have the lowest level of provision. That is actually across all of healthcare. It's a strong phenomenon, whether you look at cardiology services or general practice, but our interest here is in general practice. So what that means in reality is that a GP in the poorest areas will on average have 2,400 patients. A GP in a more affluent area will have on average 2,100 patients. And by the way, that GP in the poorer area earns 7% less. So it's a double whammy. There's greater health need, more illness and disability, and less provision.
Thank you. You identify in your report, in terms of access to general practice appointments during the pandemic, that there was a deteriorating patient experience or deteriorating patient satisfaction prior to the pandemic. And can we get up, please? This is on page 14 of your report, at paragraph 32. This is data from the Health and Care Experience Survey, which is available on the Scottish Government website. And we can see that graph begins in 2009, 2010. And there's a general decline in the number of patients rating their experience as excellent or good that continues all the way through to 2021, when it goes down to 67%. And then there's a slight increase by 2% from 2021-22 to the year 2023-24. And you've said in your report that these ratings are a function of both experience and expectations. And that it may be that patients around the time of the pandemic, their expectations were lowered. Is that right?
Yes, that's right. So there are a number of significant contributions to what is overall called access. It is about patient experience in relation to expectations. The other moving parts here are about provision, the amount of appointments, in relation to need. But on that particular point of experience in relation to expectations, say there are other graphs which show a slight uptick in satisfaction in that particular stress point of the early pandemic. And I think what that reflects is that patients are making allowances for the change in services under the pressures of the pandemic and the effect on the health system at the time. So they were probably, if you like, as they rate it in surveys, willing to make that allowance at that time. Then as services return to normal, the full influence of these moving parts, say experience, expectations, provision and need, come together again, and experience of access continues to deteriorate.
Thank you. Can we have a look, please, at, I think, probably a similar picture from England? That this is figure 2. It's at page 15 of your report. This is data from the NHS England annual GP patient survey. And we can see the blue line at the top is the overall experience at a GP practice. And as you've referred to, there's a gradual decline up to around 2020, when there's a very slight upturn and then quite a marked decline from 2021. And that graph also shows in yellow ease of speaking to someone on the phone, which is a more marked decline than the overall experience. And again, a slight lift at around 2020, and then a marked decline from 2021. And we can also see that some additional questions, I think, were added to the survey in 2018 around experience of making an appointment and satisfaction with appointment times. And we see broadly the same trend there.
Yes, that's right. And clearly what it reflects is that process of access is actually quite multifactorial. Overall, what everyone wants, everyone here has a GP, you want to be able to get an appointment reasonably efficiently and with a member of staff that you want or need. So there are other variables here, as well as ease of speaking on the phone and that experience of making an appointment. Yes, the satisfaction with appointment time, how long did you have to wait for the appointment that you were given, and also whether you were able to see the preferred clinician, the doctor or the nurse who would be able to follow through from a previous problem perhaps. So there are a number of variables at play in that overall experience of access.
Your report also highlights that ethnic minority patients, in particular, consistently report lower satisfaction with GP services in recent years. Was that based on data from England or across the UK, do you know?
So that was data from England. It was a quantitative analysis of those large-scale data from the GP patient survey.
So the general position, as far as we've seen Scotland and England graphs, is that replicated Northern Ireland and Wales?
I think so, yes. I think there are some data I've seen from Wales which also reflect a deterioration in experience of access. I haven't seen data from Northern Ireland, but again, I would imagine this is one of those examples where there is very much transferable experience across the four nations.
I think you explain in your report at paragraph 35 that there's very limited data from Northern Ireland on patient satisfaction and access to general practice. There was a single survey in 2018.
That's right. That was in that last, in the other graph that follows. There's just a single point in it. But that point about ethnic minority experience of access, I think, is important, concerning as well. So it was a quantitative analysis of those data from the patient survey nationally. So what they're able to do is analyse things that are associated with poorer experience of the general practice and access. And one of the features they found was that the proportion of patients in a practice who identify as ethnic minority groups, that is associated with poorer patient experience. It is a quantitative analysis. There's slightly limited, or shall we say, headline information available about what underlies that, but there were some issues that can be identified and which could be taken forward to improve things, such as patients' experience of using the website, but also their experience of being treated with care and concern, trust in professionals in that service, and involvement in decision-making, which happens to be a particular area of research interest for mine. So there were, if you like, some headline pointers from that quantitative analysis. What would be really useful to get into the detail of that finding about the reasons for ethnic minority populations having a poorer experience would be some more detailed, qualitative, in-depth work, such as interviews, to really get to the meaning and the experience of these things.
Sorry to interrupt again, Ms. Field. Can I just ask, when it comes to an NHS, so the NHS will negotiate with GP leaders a contract. Health is devolved around the four nations. When a contract is negotiated, does that apply in Scotland, Wales, England and Northern Ireland, or do the different devolved nations?
They develop their own contracts, my lady.
Right.
So there is a different group of GPs, largely with the British Medical Association, who negotiate that contract with each government.
Are there glaring differences, or do they usually follow much the same?
Well, as we said at the beginning, my lady, there are slight differences in the way, particularly additional and enhanced services are agreed, and we might say in Wales that we have relative underfunding compared to our peer group in England, say. So there are differences.
Sorry to interrupt, Ms. Neal.
Thank you, my lady. So in terms of access to general practice, you've identified that before the pandemic there was already an issue with that, and that the pandemic added further changes and pressures, and we'll come on to talk in a little while about some of those changes, such as the move to remote consultations. But you observed that whilst general practice did remain open during the pandemic, those changes made general practice more difficult to access for many patients and created a misperception that general practice was closed to the public and not operating. Is that right?
So I think there are definitely features of what you described there. I think essentially it's a spectrum from feeling completely closed to feeling completely open. It's not either or, and people may have reached conclusions that it was more closed and less open rather than either or. But nevertheless, so I think what I would be saying is, some patients would definitely be making that perception and interpretation of health messages, the stay at home, save the NHS message, for example. Other people will have been trying to access services as they needed it, and generally probably experiencing it in fairly normal ways, i.e. accessing via the telephone. But what was also changing at the time were these shifts towards more complete triaging by telephone and other online systems, effectively sending emails and so forth, giving details about your illness, condition, rather than turning up in person and wanting to book an appointment as in previous years. So I think it's about shifts and trends.
And do you think that the public messaging around general practice remaining open could have been improved?
So what I think is that there were definitely coherent attempts to try to maintain the message that general practice was here for business. As we said, I think there were perceptions at times that GP general practice was closed. But, for example, the Royal College of GPs certainly had a campaign that we're open for business, and applying that in the different devolved nations as well. And individual practices will have made their attempt to convey that services are here to provide. So, for example, with information on our websites or telephone messages. But in reality, say that may not have always got through. So I think, if you like, what could have been improved was a more coherent or a stronger campaign to convey what was available in general practice.
In terms of individual surgeries, were you aware that some surgeries did, in fact, have to temporarily close because of sickness due to COVID or the need to self-isolate if there'd been an outbreak at the surgery? And are there any steps you think that could be taken to minimise surgery closures in the event of a future pandemic?
So yes, I am aware that practices will have experienced significant stresses on their ability to provide, and this could be either one or two key members of staff, particularly in small practices. You know, we're talking 10 or 20 staff and employee members in a practice, and if 2, 3, 4 of those go off sick or have to self-isolate at one time, that is a significant stress on the ability to provide. And that could be either self-isolating or genuinely infected and ill. Remember, there is a context here that general practice was extremely fragile anyway, running up to the pandemic. So the experience of practice closures is not unknown. Indeed, as we established at the beginning, my own practice closed in June of 2020. We resigned the contract. So these things go on, and therefore the primary care organisations, the health boards, and now the integrated care system or boards, they have a responsibility to ensure some continuity of service. And I think what would have happened is that would have been on a case-by-case basis, working out how that could be provided in a given locality. It depends how many other practices in the locality would have had the same stress and closure at the time. So whether we'd be referring patients onward to NHS 111, for example, for telephone advice, or perhaps to a neighbouring practice, it'd be a case-by-case solution finding, I think.
Thank you. Can we move on now, please, to look at changes in general practice during the pandemic? And you've identified in your report that in addition to, at least initially, a drop in the overall number of general practice consultations at the start of the pandemic across the UK, the most prominent change probably to the way that general practice actually operated was the shift towards remote consultations. And could we have a look, please, at figure 7? That's on page 32 of your report. This is a graph from the Health Foundation based on English data, I think. And could we, thank you. I think we can see there the red line is face-to-face appointments, and the blue line is telephone appointments. So we can see that while it's quite a jagged line, the red line along the top, there was a very rapid drop-off in around January, February of 2020, down to April of 2020, when there was the biggest drop. And mirroring that, an increase and a sustained increase in the number of telephone appointments. And then we see that the number of telephone appointments continues from around May 2020 and June 2020, when it's at its highest point, and continues in a similar vein through to the end of that graph, which is March 2021. But we can also see that although there was an initial drop in the number of face-to-face appointments, that then began to pick up again as we moved through into 2021. And you've noted that this graph may in fact overestimate the number of face-to-face appointments and underestimate the other types of encounter, because the default setting for appointment diaries, if I can put it that way, is face-to-face. Is that right? Thank you.
That's correct. So as we see, the percentage of telephone consultations was around about 13% in those years before the pandemic, and it rose to something of the order of 47% in that immediate pandemic phase.
Thank you. I wonder if we can move on, please, to look at figure 9. This is some data from Scotland. This is on page 34 of your report. And if we could zoom in. Thank you, Lawrence. We see a similar picture there. I think the dotted line is lockdown in March of 2020. And we see, again, face-to-face appointments, the dark blue line, and the purple line showing virtual appointments. And it's showing the same sort of trend that we observed in the data from England. Is that right? A sharp drop in face-to-face appointments around the time of lockdown, and a similar increase in the number of virtual appointments.
That's right. My apologies. I'm not very good with colours. I'm colourblind. But the top line is the physical or the more face-to-face appointments, and the bottom line is telephone or virtual. And so I think the other point that should be made about this graph and the one before is that the key point is to add the totals together as well to see how much activity was going on. So in that early phase, there is actually a net drop in total activity, but then quickly, not only do we establish a new normal of the proportion which are telephone-based or other remote methods, but actually the totals now exceed those prior to the pandemic.
Thank you. Now, Professor Edwards, you go on in your report to explore a number of issues with remote consultations in general practice, and I don't think we're going to be able to address all of them this morning, but one point that you make is that some patients could be described as digitally excluded. Could you explain what you mean by that, please?
So I think the issue that we're wanting to describe and ultimately help with are patients who are not finding it so easy to use these remote methods, sometimes digital, sometimes telephone.
And what sort of groups of patients would they be?
People who have more difficulty with either telephones or computers. It might be typically older patients, sometimes less educated, sometimes socioeconomically more deprived. Also, actually, probably sometimes the ethnic minority groups that we mentioned earlier. They specifically identified in their GP patient survey difficulties with accessing the practice website. So there's a range of groups who are typically more deprived and have more difficulty.
Would that also include patients with disabilities such as sensory impairments or learning difficulties? Would that be more difficult for them?
Yes, very much so. And depending on the nature of the disability, the particular route of access, whether it's say, telephone or website, may be more difficult or less.
Were you aware of any initiatives or measures taken either at a national or a more local level during the pandemic to ensure that those people who were digitally less able were not disadvantaged by that shift towards online bookings?
So in terms of what I think you described there as a national exercise, that would be implemented in different ways, probably in the different 4 countries. But nevertheless, I'm actually probably not aware of specific programs that were undertaken to achieve that, except that I think there was an awareness of it, a genuine knowledge and awareness, and an imperative to try to assist people so that as we switched very much wholesale to remote access, triage and consulting in those early months of the pandemic, there was a specific attention to people with particular needs at a practice level, I think, ultimately.
Now, you set out various issues with how general practice can make that shift towards remote consultations. And you point out that it's a different skill set and some further training is needed really to enable the practitioners to both assess what's the most suitable mode of consultation and then carry out that consultation. And I think you identify in your report that there were a number of pre-pandemic studies and evaluations of moving to remote consultations in general practice, which identified a lot of those issues. So my question is this. Do you consider, or to what extent do you consider, that those challenges or potential drawbacks of moving to a remote consultation model during the pandemic were foreseeable issues at the start of the pandemic, and did they appear to have been properly taken into account when general practice was asked to make that move to increasing the number of remote consultations?
I think there were really useful findings from those evaluations before the pandemic about telephone consulting and related issues of remote access as well as provision of services. So I think that, for example, that's what contributes to the knowledge and awareness for digital exclusion and other aspects of social and economic disadvantage as concerns to tackle. So that's why the knowledge and awareness was there when we made that change. Sorry, I can't completely remember the second part of that question. Was more.
Did that knowledge and understanding appear to have been factored in to the direction to general practice to move to remote consultations, which happened quite quickly at the beginning of the pandemic?
Yes, I think factored in is a very reasonable summary of it. So, for example, there were documents from NHS England about moving to total triage and also remote consulting, supported by Royal College of GPs and so on. So yes, factored in. How we operationalise those solutions, I think we probably needed more. As I say, we had knowledge and awareness so that at practice level we could try to make adjustments to allow for the needs of particular patients. I remember practice staff, they get a lot of knocks, but one thing they're very good at is knowing their patients, and they'll know particular patients who have those particular needs and how to try to help them. So I think it was a reasonable direction of the way things were going, but I think actually probably more detail about how to support that could have been valuable.
Thank you. I think that brings us probably to the question of the degree of pandemic planning and preparedness that appeared to have been undertaken in terms of proactive planning for general practice. I think you undertook a review of the pandemic planning for healthcare that existed in the 4 nations and the extent to which that planning included primary care. And I think your conclusions in that were that preparedness largely appeared to have been in terms of a repeat of the influenza pandemic scenario. This is, I think, at paragraph 58 of your report. The planning did not specifically address primary care needs and continuity for non-pandemic conditions, nor the contribution of primary care to the management of patients in the community as part of an overall healthcare delivery strategy in a pandemic. Is that a fair summary of your findings?
Well, the reason I was examining the preparedness work across the healthcare system was because I started looking at what had been done for preparedness in primary care and found very, very little. Therefore, it was reasonable to look at what had been done across the healthcare system. But I think that the key point is there was very, very little specific work for primary care preparedness that was available to look at. So, in my view, much more should have been done. There were elements that some would argue from the preparedness work that had been done looking at the strategy about how to deal with things and the principles, but I would say operational preparedness was much more important to actually enable things to carry on when the challenge came in March, April of 2020, it really wasn't there. And I think, to be fair, we were flying by the seat of our pants.
Can you give any specific examples of what, if somebody had addressed the issues you're talking about, they might have done things differently in their planning?
So I think there are many areas that we would want to examine for preparedness. It would be issues around managing a range of presenting illnesses, but particularly the presenting illness of note in the pandemic, i.e. COVID. Also continuing healthcare problems, health promotion, issues of health-seeking behaviour, communications, vaccination, issues of managing risk and so on. But so, for example, that one of looking at managing the acute presenting illness, many adaptations were required in terms of how practices made that provision when patients were ringing up and consulting and sometimes needing to be examined. How would we do this in terms of high-risk areas of the general practice building, for example, or using a branch surgery as our, quote, hot, unquote, area for consulting? This was all largely, as I say, generated as we went along in those early weeks, whereas consideration of that in advance would have made things that much more efficient. And relating to sites, you've got issues of getting the protective equipment in the right place, getting oxygen cylinders and oxygen saturation monitors in the right place. So all that preparedness and planning could have been that much more specific for primary care, would have been really helpful.
Thank you. You've also identified in your report that you consider, this is paragraph 61 of your report, that specific planning is required to minimise the unequal impacts of future pandemics, including those from Black, Asian and minority ethnic groups. And could you identify what that specific planning for primary care might entail for future pandemic planning?
Well, I think it's similar to that last discussion. It's thinking, okay, what would this look like about how we're going to provide for patients with the acute presenting illness or ongoing needs and other areas of screening and health promotion, etc. And relating to that, thinking, okay, what does this look like for particular patient groups, the elderly, ethnic minority groups, etc. So if we're thinking about long-term conditions, for example, higher prevalence of diabetes amongst ethnic minority populations, how are we going to keep these services continuing to function effectively when those challenges happen? So those are the sorts of specific things that we could have identified and made plans for.
Would that also include planning for patients with disabilities who may struggle to may also have other long-term health conditions or may struggle to use remote consultation methods?
Yeah, absolutely. So there's a number of particular risk groups, as I mentioned elderly and ethnic minority, disabled persons, absolutely. We've actually mentioned the digitally excluded and people with lower educational attainment to be able to use the information resources that we have. So there's a range of particular groups with more needs, more challenges, and greater risk.
You mentioned there the ongoing long-term conditions, and again in your report, this is at page 49 of your report, you identify patients who were missed during the pandemic, and you've highlighted there a study, in fact, using the SAIL databank from Wales, which looked at a number of specified long-term conditions, and it identified a very large potential backlog of undiagnosed patients. Is that right?
Yes, that's correct. So we're using the routinely collected data from general practices and hospitals in Wales, and looking at a number of these long-term conditions. These were the standard long-term conditions that we would have been addressing in the quality outcomes framework that we mentioned earlier. So these are the regular conditions that quite rightly get considerable attention to diagnosing and then following up with evidence-based clinical management. So we identified that during that period in 2020 and thereabouts, fewer patients had been identified, been recorded into the database, making that diagnosis for the first time. And if you haven't got the diagnosis, then you're unlikely to be getting onto a register, and then unlikely to be getting called and recalled for the ongoing management. So we've found these dips in diagnosis and recording of the incidence of these conditions across the board. The graphs are very consistent, whether it's asthma or blood pressure or coronary heart disease. And what we found was that, okay, through 2021 or so, the numbers returned pretty much to the baseline levels. And at first sight, you might think, well, okay, so there's been a dent in the figures and an impact, but a recovery. But actually, when we think about it, those numbers should rebound above the baseline in order to make sure that those patients lost in the previous year are also in the total for the next year. So there is actually there's evidence of a backlog there. Okay, those data were from 21. I think we actually need to repeat that exercise, really, with further research to identify what is the extent of the backlog now in 24.
And I think the extent of the backlog that was identified in the study you mentioned from 2021 was that a GP practice of 10,000 patients might have over 400 undiagnosed long-term conditions that would in normal times have been picked up and diagnosed.
That's exactly right. That's the scale. And just to note that those 400 would not necessarily be 400 different patients. Some patients might have had more than one of those conditions. But yeah, 400 missing long-term diagnoses in 10,000 patients.
Thank you. And your report also highlights that there has been a reduction generally in help-seeking behaviours from patients during the pandemic, so patients not coming forward with the symptoms that might normally trigger those sort of investigations. And it also notes the findings of some online surveys that identified a significant proportion of respondents had been unaware of the infection prevention and control measures that were in place in general practice surgeries, such as separating COVID patients from non-COVID patients and so on. And it concluded that almost a third who had delayed or avoided contact would have felt more comfortable contacting general practice had they known what measures were in place to keep them safe. Whose responsibility was it to communicate to their patients that there were these measures in place? Is that something that should have been happening at a national level or a health board level? Or was that down to the general practice surgery to make sure their patients were aware?
So I think it's a shared responsibility, and I think it is pretty much the similar point that we made earlier about the messaging about being open for business in relation to the stay at home, save the NHS message. We were open for business, probably a clearer, more coordinated campaign across all those stakeholders. You mentioned national, regional and local practice level, also with significant stakeholders such as the Royal College of GPs and others. That clearer, stronger message would have addressed exactly those issues about patients' fears that there weren't sufficient precautions of separating higher risk from lower risk patients and so on.
And obviously that would have been particularly a concern to those patients who had been identified as clinically vulnerable or clinically extremely vulnerable because of other long-term conditions that they had.
Yes, it would, although we also note that in those studies about remote access, in fact, probably some groups actually found it more accessible, certainly in relation to their context, and I think that would be particularly for patients with who were clinically extremely vulnerable, who actually would have found, who did find, they reported that in the evaluations, they found it a reasonable way to access services more than they would have otherwise been able to do. So there's quite a complex interplay of factors.
Thank you. Can we move on, please, to look briefly at that section of your report that deals with how pulse oximetry was used in primary care to monitor patients with COVID-19. This is pages 53 to 60 in your report, if that assists. Could we begin, please, by having a look at a pulse oximeter? This is on page 54. Thank you, Lars. So this is a photograph of a typical pulse oximeter. Could you describe very briefly how this is used and what it's used for?
So it is this small monitor which is intended that usually someone's finger or maybe thumb, sometimes a toe, in the case of children, might be inserted into the gap between the two halves of it to press onto a monitor. And that monitor is picking up both the oxygen level, that's there as SpO2, 98% there, which is good level, and the pulse rate at 62, which is a fairly normal pulse rate.
And I think these were proposed to be used or were used during the pandemic to identify those patients whose blood oxygen saturation levels were deteriorating but didn't have other symptoms of deterioration. Is that right? Is that so-called silent hypoxia?
Well, that is silent hypoxia. I think there's a genuine discussion to be had about what was intended in the monitoring programs and how they were interpreted as to whether it was exclusively a measurement of oxygen for silent hypoxia or whether actually it should have been part of a package of care assessing the clinical state of the patient, other key measurements, their temperature, their blood pressure, etc., but also how they're feeling and getting on. What's their appetite like? Are they feeling sick? Breathlessness, and so on. It's part of a picture of the patient's clinical state, as well as their support at home by family or others as to how they're actually managing with this condition. So I think one of the key problems with oximetry is if it becomes a measurement in isolation.
And in terms of those other symptoms that you mentioned, if a patient had silent hypoxia, would those other symptoms be absent?
I think it varies. Theoretically, yes, you could have just a silent hypoxia and be reasonably well, apparently, on the basis of those other measurements or lack of any symptoms. I think more usually it was an additional feature to a patient feeling generally very unwell.
You explained that how pulse oximetry was used across the UK or even within countries of the UK varied a great deal. And you mention in your report that in your practice you received a box of pulse oximeters in early 2021. So what was your experience of how that pulse oximetry was intended to be used? Did you get any instructions with that box of pulse oximeters? How were you supposed to use them?
Well, first of all, I was particularly interested in this issue because just a few weeks before, I'd been involved in putting a proposal to the primary care programme of Welsh Government for evaluating a programme of implementing pulse oximetry. And we'd been invited to put that proposal in, but ultimately through those few weeks around Christmas of 2020, I think, it didn't come to fruition to lead to a more structured programme and an evaluation. So I was interested, but then a few weeks later, this box of pulse oximeters arrived in the practice. And so from memory, it was about 20 or 30 of them. And I don't believe there was very much instruction about how they were intended to be used, and still less any instruction about recording data to evaluate how they might have gone.
So how did you use them?
So we used them by making them available to clinicians to give to patients. So first point is there were more, I think it was unclear what they were intended for, as we saw it on the ground, as to whether it was for staff or for patients, but there were more oximeters than there were staff. So we assume that it was actually intended to be given out to patients, and that is indeed what we did.
So that your patients could monitor themselves remotely at home?
Yes, and particularly if they couldn't access one themselves quickly.
Rather than the GPs taking the readings when the patient came into the surgery?
Yes,
Yes.
and part of that, I think, is lack of clarity about what the programmes overall, this includes, I think, Wales, Scotland and England, was it for self-monitoring by a patient at home? Was it actually home monitoring with support by the clinical staff? And if it was home monitoring by the clinical staff, which patients were involved? Was it those presenting to general practice? Was it those who had presented to emergency departments and been discharged, who, by the way, would be largely likely to be sicker, or patients discharged from hospital?
So none of that information was forthcoming with this delivery?
I
of
don't recall
hospitals?
that, no.
You mentioned that you had put together a proposal for evaluation around Christmas 2020 or before Christmas 2020. I think the Chief Medical Officer of Wales issued a Welsh health circular to GPs encouraging the use of pulse oximetry monitored by GPs, so the recordings taken by GPs, and that was on the 4th of August 2020. So would it appear to have been after that Welsh health circular had been sent out that you submitted your proposal for evaluation to the primary care
Yes,
body?
3 or 4 months later.
Thank you. You've also mentioned in your report that you're aware that there were some concerns regarding potential inaccuracies in pulse oximeter readings in darker skins or more pigmented skins, and that was raised in December of 2020, and NHS England issued advice in that same month in relation to the pulse oximetry programme in England. And you say in your report you haven't located any evidence about the extent of awareness of that advice amongst primary care staff. As you were working in general practice in Wales at that time, did you receive any advice in your surgery about those potential inaccuracies in pulse oximeter readings, either in December 2020 or subsequently in 2021?
So I actually don't recall receiving it. I couldn't guarantee that we weren't sent that information.
Thank you. If we can move on, please, and look at the impact of the pandemic on the general practice workforce. And can I summarise, please? You've given quite a detailed analysis in your report over pages 63 to 75. But you identify a general trend, which I'm going to summarise in this way, and tell me if I'm wrong, please, that across all 4 nations of the UK, there was noted to be an increase in the general practice workload over several years, both pre and through the pandemic, a decrease in the number of full-time equivalent GPs, and an increase in the number of patients per general practitioner. And you've concluded that it's not clear that the pandemic has had a direct effect on what were clear trends from before the pandemic. And you also identify in your report that in addition to those trends, there's also a noted decrease in the GP partner workforce, and that also has some quite important implications for the resilience of the sector, which will affect how well it's able to respond to a future pandemic. Can you explain how the reduction in the GP partner workforce is likely to affect the resilience of the sector?
Okay, yeah, thanks very much. So that's a great summary of some of those key statistics about reducing numbers of doctors and increasing numbers of patients per doctor. The other feature that I think actually is quite relevant is the increasing complexity of patients' health and healthcare needs per patient. So there is a steady increase in the number of people with long-term conditions, been rising 4% per year. There's a steady increase in the number of patients with multi-morbidity, more than one long-term condition, rising 8% per year. So what that means in reality is that 2/3 of people over 65 have 2 or more long-term conditions. And by the way, that probably means they're taking 4 or more medicines. So it's workload and complexity as well as actual numbers. And I think that's actually where it's very relevant with the GP partner workforce, because they are typically the most experienced members of the teams. So they are able to bring that experience to bear on the delivery of high-quality general practice, characterised by a coordinated, comprehensive service, hopefully with continuity of care as well, for complex medical and social care needs, and then assisting the team, the primary healthcare team, in that provision. So it's education and it's mentoring and it's training, either for those genuinely in training or those who are actually in post and still require that education and mentoring, such as the advanced nurse practitioners and the pharmacist and other members of the team. They are independent professionals, but nevertheless, there is still that role. I mean, ultimately, it's about the legal responsibility in the practice, which is held by the partners. So they need to have that role. And if that partner workforce is eroding, as it has been over the last 20 years, we've lost a quarter of the partner workforce. That actually has a serious impact on the ability to deliver and develop services going forwards as needs continue to rise. And as you said, the point is, okay, that's the situation now, but if we're actually also talking about the resilience of the primary care sector to be there and be ready to deal with the next pandemic, then we've got a real problem to tackle.
Thank you. So, having looked at the impact of the pandemic on the workforce and the sector more generally, could we move on to look at a more individual level and the impact of the pandemic on general practitioners' mental health and their emotional well-being, and indeed their physical health? I think it's not been possible to identify any data on sickness absence rates in general practice, specifically in general practice rather than across the NHS, is that right?
Yes, I think largely stemming from this contractor status of practices as independent businesses. I don't think they have to provide those data to health boards and others who would put them together. So those data are actually largely unavailable.
And although you have been able to identify data on sickness absence rates across the NHS, which has shown an ongoing and sustained rise over the pandemic period, I think it's right that those figures don't actually include GP staff. They're not counted in those overall figures.
I think that's correct, yes.
So we can try to extrapolate something from that, but as you've pointed out, the situation in general practice is quite different from the situation in hospitals in terms of the infection prevention and control measures that are in place.
Yes, so this is an example where we were talking about earlier. We can't generalise from those data, which are largely from the hospital-employed services in the NHS, but we can try to identify transferable lessons. What is happening about sickness absence in the primary care workforce?
So although there's a lack of quantitative data on this, you have identified qualitative data, and particularly a survey by the British Medical Association of its members about their experiences of the pandemic and the way that it had impacted upon them. And I think you set that out around paragraph 256 in your report. And the BMA survey also identified general practitioners specifically who responded to the survey, and you've included some quotations from those GPs in your report, and they've identified a range of concerns. Perhaps I can summarise them in this way. They noted hazardous workload levels in general practice, a lack of representation for some ethnic minority GPs, emotional impacts of increased patient deaths in primary care, moral injury and moral distress, burnout, demoralisation, experiences of abuse of GPs, and a serious deterioration in their physical and mental health. And you go on to say that that BMA survey raises some important issues for further consideration. Could you expand on that and the nature of that further consideration that you consider is needed?
Yeah, so as you say, I've drawn those comments. They were the ones which were from GPs amongst a whole range of contributions to that BMA survey. But maybe just to, in terms of what that looks like in general practice, maybe to try and put a little bit of story into it to help us understand. So in my own practice, for example, during those early lockdown months, we had 2 patients who died. One was a woman who was a victim of domestic violence, which led to a prosecution. And one was a young boy with type 1 diabetes, 11 years old, who had not presented at all to us. So we talked about those figures of long-term conditions being missed. That's what that looks like. In the extreme example, an 11-year-old boy died because he didn't come to any healthcare. And by the way, he was not in school either at the same time, where someone might have said, he looks pretty unwell, you better take him to the doctor. So this is a huge shock. Again, our staff know the patients. Most of our staff live on the same 2 housing estates where our 2 surgeries are. Friend of a friend, tight-knit communities, everybody knows everybody. And then these deaths and what appear to be avoidable deaths occur. Again, we'd had alerts from the local paediatric service in April, May, June, saying we normally see 4 children per month with new diagnoses of type 1 diabetes. We're not seeing any. They must be out there. Please be alert. So everyone was on it, and yet, a variety of constellation of factors. This child was not brought to services, and it makes a huge impact for everyone concerned. Clearly, obviously, a tragedy in the family, but in terms of the impact in the family, in the practice family. It really makes a significant impact on us all, and then it's about how do we respond to that and support each other. And
Can I ask you, please, about the support that was made available to GPs during the pandemic? You've identified at paragraph 266 that interventions to improve well-being are crucial, not just for those GPs who are affected, but also to improve the resilience of the sector for future pandemics. But you identify that factors that contribute to poor psychological well-being and negative outcomes, such as burnout, are poorly understood. In terms of the support that was made available to GPs during the pandemic, were those interventions at a local level or a national level in terms of support by national bodies?
So I think we need to consider that there would be different provisions across the 4 countries of the UK. In my experience in Wales, there were services which were available to professionals, so therefore not all of the primary care team, for example, the administrative members, but professionals would be able to access help for their health problems through confidential inquiry lines, etc. I don't believe those services were changed during the pandemic. I think there were specific services that were available in NHS England for primary care, but which have now been made more generic across the health service. So I think that there's variable provision. What we're left with is a lack of primary care specific support, both what you might call treatment, including issues of burnout, and also health promotion and prevention in terms of promoting well-being, and how to support that across the workforce to make sure that the sector is resilient. So that is lacking at the moment.
Can I ask you about one other very specific matter in terms of supporting general practice staff during the pandemic. One of the issues raised in that BMA survey, or by one of the participants in that BMA survey, was the need for mandatory risk assessments, and particularly for black and minority ethnic staff in general practice. Where did the responsibility lie for carrying out risk assessments for GPs? Would that be at surgery level, or was that from the local health board, or beyond that?
So I think it is connected with the contractor status of practices, which is that the practices are their own businesses and they are responsible. What I think actually, nevertheless, is relevant is the context in primary care, both before and during the pandemic, which is an extremely fragile service, variable from reasonable to very weak. And in that context, where it is very fragile, I think actually practices need support from their organisations, the health boards and integrated care systems or boards, clinical commissioning groups as they were back then. So I think actually to enable it to happen reasonably and effectively, the practices do actually need that support. So I didn't personally experience a risk assessment. By the way, I felt that I probably had a couple of risk factors at the time in the early pandemic by virtue of age and gender.
And were you aware of any other GPs who hadn't been given risk assessments?
I'm not aware of GPs who had. I'm aware of some other GPs in the locality who made specific efforts with their practices. For example, a very well-known member in a practice nearby with a position of seniority in the profession, and she said in her practice, "Look, I'm 60. I'm from an ethnic minority. I think I've got some risk factors here. We need to make some adjustments in the way I'm seeing patients. Should I be doing the on-call, for example?" So I think it was probably left to individuals to make the running often.
Thank you. If we can move on, please, to your recommendations for general practice, and how best to equip general practice to be able to cope with a future pandemic. And you set out a number of recommendations or potential recommendations in your report. And I'm not going to go through all of them, but you identify, I think as a headline, that resilience of the general practice sector is key. And could you give us a summary or the headlines of what areas you think are key to address in order to improve resilience so that the general practice sector is equipped for a future pandemic?
Thank you. So I think the key to it ultimately is about the workforce and the workload, and what that actually means is about resource and provision into the general medical practice sector. So resource as a proportion of the NHS budget has reduced over the last 20 years from around about 11% of the NHS now down to the 8 point somethings, possibly even less, for example 7.6% in Wales. So at the very least we need to get back to 11% of the NHS budget into primary care. That's therefore a 30% increase on where we are now, just to stand still, I think, just to deal with the levels of provision that are made in relation to need, which is rising, and the workforce trends, which are actually very significant. So reducing full-time equivalent numbers at the time of increasing patient numbers and increasing patient complexity. So ultimately, we've got to get that resource into primary care. It's not about profit for individuals, it's about resource into the sector. And that means a sustained plan of the right numbers that are needed, both GPs and other staff members, nurses, pharmacists, and various. But basically, political priority to deliver on those numbers. We've had targets and they haven't been achieved. It's absolutely essential that we get back to where we were and then to try to improve it. in terms of looking at different ways of working, more integrated systems between practices, different ways of providing care as care is shifted to community and for prevention. And whilst also thinking about resource, which really is the key factor, we also need to be looking at issues for the workforce, but supporting individual resilience, well-being, and dealing with those with particular issues of burnout.
Thank you very much. I've no more questions for you. Thank you, Professor Edwards. I wonder, my lady, we're a little
No, I
bit
have no other
past
questions. I don't think there are any questions from core participants. Professor Edwards, thank you so much for your help, both in producing your written report and in your oral evidence. And please rest assured that if there's anything you haven't covered, I will be very much taking into account your written report as well as your evidence this morning. So I'm really grateful for your help.
Thank you, my lady.
I shall return at 12:05.
All right.
My lady, may I call Tracy Nichols?
I swear by Almighty God
I swear by Almighty God
that the evidence I shall give
that the evidence I shall give
shall be the truth,
shall be the truth,
the whole truth,
the whole truth,
and nothing but the truth.
and nothing but the truth.
Thank you.
Thank you. Good afternoon, Ms Nichols. Can you state your full name, please?
Yes, Tracy Lee Nichols.
Thank you. And you have your signed witness statement in front of you. That is INQ 30281189. Ms Nichols, you're here today to give evidence on behalf of the College of Paramedics and its members as the Chief Executive, a role that you've held since the end of 2019 to date. Is that right?
That's right.
Thank you. And you're a qualified paramedic yourself since 1998?
Yes.
And before holding the Chief Executive role, it's right that you were the Director of Infection Prevention and Control, or DIPSI, and Director of Clinical Quality and Improvement at the East of England Ambulance Service. Is
That's
that
right, yes.
And the College of Paramedics has approximately 22,000 members representing paramedics and students across the UK.
That's correct.
Was the college involved in any pandemic planning prior to COVID-19?
No, not in so many words. We were aware that obviously in my previous role there was annual pandemic flu planning, and something that the college was at a stage in its growth where we felt it needed to start thinking about things of that nature. However, I wasn't expecting within 3 months for that to become a reality, even though we knew that the flu was circling. We certainly didn't have the capacity to start anything of that nature, but it is something we should do as a professional body.
And that brings me to my question. Is it something that you think it would be beneficial to be involved in future?
Absolutely.
When did the college start?
2001.
Thank you. Moving on then to the college's relationships and representation during the pandemic. From 23rd to the 25th of March, there was a centralisation of ambulance services in England into the National Ambulance Coordination Centre. Was the college involved or consulted by the centre during the pandemic?
No.
And from your experience, was the decision to centrally coordinate ambulance services in England one that was effective in allowing a response for the ambulance services in England?
I think certainly operationally that was the correct process to happen. I think what that missed is the professional body support and capacity to help.
And did the college seek to offer that help?
So we certainly we knew of each other's existence. We had regular contact, so it wasn't like we didn't know each other existed, but we didn't formally say, "Do you want some help?" Because they're normally very good at cracking on with things on their own.
And another cell that the college was represented on was the frontline clinical cell, which is the NHS England Emergency Preparedness, Resilience and Response Team. Can you provide some examples of the issues that were considered by the cell and how effective that was in the ambulance context?
We had no involvement with that at all, I'm afraid, so I couldn't answer that.
Okay. The inquiry's heard some evidence about the UK IPC cell. The Association of Ambulance Chief Executives, or AACE is the acronym used, represented the sector on that cell. In your statement, you have said that there was no formal route to having information from the cell, either from the AACE or from NHS England. Is that right?
That's correct.
And did you raise any concerns about that during the pandemic?
Yes, we did, and we facilitated some meetings with the ambulance representative on the IPC cell through semi-regular meetings.
And did that lead to any changes?
No.
And so without those formal communication channels, how did the college receive information that was agreed at that cell?
Pretty much through scouring the websites ourselves, through speaking to stakeholders, other professional bodies, other allied health professions, of which paramedics are one, and really the same way that everybody else was finding out. Really, we didn't have any formal route as such.
And looking to the future, do you think a formal route for channels of communication would be beneficial?
I do, because it certainly helps support information rollout. We have a huge amount of membership, so it certainly would help facilitate when changes are being made that we could link in with the Association of Ambulance Chief Executives and provide combined support and communication, but also sometimes that critical challenge from a professional body lens that isn't necessarily in with the ambulance sector. Our members work within the ambulance sector and outside, for example, the military and independent sector as well. So we're not just ambulance sector focused.
Thank you. Moving on to a slightly different topic now around the ambulance workforce. The inquiry understands that there was a big effort to increase the workforce, particularly call handlers at the very start of the pandemic, both in 999 and 111 services. So were you aware or involved in any of those recruitment drives at the start of the pandemic?
No, we were aware that the 999 call handlers were impacted by the COVID virus as well. They're historically a very low paid workforce and it's always difficult to retain the call handler personnel because the private market often offers more money, but also, it's a very, very draining and demanding role answering the calls to the public. So we knew that psychologically people were suffering and also that they were catching the virus as well, but we had no involvement in the recruitment. That would be the ambulance sector itself.
And you've spoken there to one of the barriers perhaps being pay and the working conditions. In the context of the pandemic, were you aware of there being any other barriers that might have prevented recruitment of 999 or 111 call handlers?
I think people wanted to help. The ambulance service is a great way for people to feel like they can help the public. The realities of that job are very arduous. The calls just keep coming in. And it's a very difficult job. It takes, I think it's 12 weeks of training normally. And I know some ambulance services tried to reduce that length of time for call handlers, but it's a very technical job. The call handlers are trying to type information and speak to the caller at the same time. And it's, it's very difficult when you're dealing with someone and you can't see what you're dealing with. That's quite psychologically difficult for people. So it's not for everybody, but people did come through the recruitment during COVID because they wanted to help.
And people at the other end of the call, the person making the call is likely to be very distressed and in a state of panic.
Yes, absolutely.
And that perhaps brings me to one of my questions around training. Were you involved in any of the training that was delivered during the pandemic, and did you receive any complaints of issues or concerns around the training that was provided to not only the new recruits, but also those that were dealing with the unprecedented situation they found themselves in?
Certainly not for the call handlers. We, as I say, it's a very technical role that the ambulance service is very good at doing the training for. Where we did have an involvement with was the student paramedics, and we have a good relationship with all the higher education institutes, so all the universities that offer the paramedic programme. And what we did see is that some of the clinical placement, those areas where people try and put into practice what they've learned in a theoretical way, that some of the students, or quite a large number of the students actually were coming to us saying the clinical placements are no longer there. The very way that we try and sort of support our practice under supervision is no longer available. And they understood in the main that that was because placements were very difficult. Nobody knew how safe it was for students to go onto the ambulances. So quite often they were diverted into the control centres or to do stocking of medications, etc. But we were involved in liaising with the higher education institutes and the Association of Ambulance Chief Executives to say there are trusts where students are falling through the gaps. There is no real liaison with the higher education institutes in some areas, so students are not really sure how they can help, and actually if they want to help, because they didn't have to, that wasn't part of their contractual obligations as a student, but many of them obviously wanted to.
Thank you. And I have two questions arising out of that. The first is around whether there's been any long-term impact of students on students' development and education during the pandemic, and whether any support was offered or put in place during the pandemic or since then to allow them to catch up, to ensure that it doesn't impact the workforce longer term.
I think where the students were nearing the end of their course, we believe there's been much less impact because they were ostensibly ready to go out with some additional supervision. Where students were in year 1 or 2, that's very, very different. And because they haven't had the exposure, as with many other healthcare workers in other professions, their confidence levels have suffered. And certainly as a college, we've spoken about doing a retrospective study about how people feel post-pandemic in their profession. And we also are starting to see early signs that people who did join as students during the pandemic are not staying in the profession.
Thank you. Moving again to a slightly different topic around capacity, this time the capacity of ambulance vehicles. You've had sight of the response the inquiry received to the research it commissioned into escalation of care, in which 45% of paramedics and 55% of general practitioners said that one of the barriers to escalating care was access to an ambulance. Was that a complaint or an issue that the college was aware of during the pandemic? And if so, did it take any action to escalate those concerns?
Yes, in terms of access to being able to get an ambulance to go out and do your shift on, we were aware that there were vehicles that were tied up at the emergency departments, meaning that crews that were coming on shift couldn't access an ambulance to start their shift, for example. And it wasn't unusual for a crew that were coming on either in the morning or the evening to have to go and relieve the crew in the car park of the hospital so that the off-going crew could get home. And also there were a number of vehicles that were off the road due to mechanical, that's, you know, when a service runs as hot as the ambulance service does in terms of constant demand, constant calls, the vehicles don't tend to fare very well and don't last very long in some aspects, so brakes fail, etc.
Yeah, and looking at the wider picture, obviously you've spoken a bit about the impact on the workforce of a lack of available vehicles. What was the impact on the patient care, the treatment, and the time that perhaps it would take, therefore, for an ambulance to respond?
It's horrific. It's absolutely horrific. There were ambulance delays before the pandemic, but they worsened certainly after the first lockdown. You know, if you put yourself in a patient's position of calling for an ambulance, being told that they can't guarantee when one is coming, and then calling back maybe an hour, 2 hours later, and still nothing's coming, the ambulance service can't give you an ETA because calls are coming in all the time, and then maybe a higher priority call comes in, that pushes other patients further down the line in the queue, which is a terrible state of affairs when the demand is so high. So the crews were very aware of not only the terrible patient experience of someone sitting in an ambulance with them outside the ED for hours, they were also acutely aware of all those patients who had not been seen by any healthcare professional waiting in the community and quite often deteriorating.
Thank you. On the topic of sickness rates in the ambulance sector, you've said in your statement that ambulance trusts recorded the highest rates of sickness absence across the NHS. What does the college understand contributed to such high rates, both on the front line, but also in the call handling centres, the emergency operations centres, and those non-clinical areas as well?
Well, mostly it was, in my view and the view of the college, it was the failure to provide adequate respiratory protective equipment. The back of an ambulance is very small. It's the new specification from NHS England is a Fiat Ducato. That's 3.67 metres long by 1.84 wide, with the equipment also added in there. And that makes you around 900 millimetres from anywhere you're sitting from a patient. And even in that's in the saloon, that's the back of the ambulance. The cab is where the crew and the attendants sit. That too is around 900 metres, you're 900 millimetres from one another there. The control room staff are all sitting in a large room, not dissimilar to this. And infections can spread very easily. You know, you have outbreaks of, you know, in normal times of sort of diarrhea and vomiting, and you can guarantee pretty much that will spread around a large space like that without good adherence to infection control procedures. But for the pandemic, I have no doubt in my mind it was a failure to protect the paramedics and the ambulance clinicians.
Staying on that topic then of infection prevention control in the ambulance sector, you've gone into some detail about this in your statement, starting at paragraph 10, and you've said that the guidance that was disseminated at the start by the government bodies, for example, Public Health England, was often confusing and contradictory to the evidence from other professional organisations. And the lack of clear guidance had a profound impact on the members of the college and their ability to do their jobs. And you describe how a one-size-fits-all approach was taken to the guidance and that the college sought to fill that gap. And presumably that's the IPC guidance there that you're referring to. Filling that gap, is that a role that the college played prior to the pandemic?
Yes and no. I mean, you know, I'm struggling with the lack of common sense to understand that not all environments are the same. The ambulance sector is very unique, and I'm sure a lot of professions would say the same, but the environment that the profession works in is very unique in the ambulance sector.
Can you give us some examples of how it's unique?
So you are going to a 999 call or a 111 referral. It may say, for example, on the screen that you're going to a patient who's fallen. Now, that fall could be a simple trip or slip. That could be that someone has tripped and hit their head and fallen. It could mean that someone is suffering a cardiac arrest, but the person that's calling has just seen them fall. So you're going to what we call undifferentiated patients. So it means you don't know what has actually happened until you get through the front door or inside the office or wherever that patient is. And that's the only time you truly know what is happening. So the idea of making a risk assessment about COVID-19, for example, was impossible because you didn't know what you were going to. You rarely do. And I think there is something around paramedics and ambulance clinicians are very good at a sort of a different risk assessment. So that is there anything in this area that I need to be careful of immediately? Is there a dog that's going to be very protective of the owner? Is there drug paraphernalia on the floor that I need to be cautious of? Is there, something that's going to harm either yourself or the patient? So we describe it as sort of bandwidth. You have a certain amount of bandwidth to check all of that as you're going in towards the patient. Then you've got the COVID aspect on top of that, which behind a front door, you're going into invariably a closed space, no windows open. And if I can be honest, not everybody obeyed the lockdown rules. So you might have thought you were going to one patient with a relative, and actually there'd be 3 or 4 relatives there because they're genuinely concerned for their relative and have been waiting a very long time. So the exposure to risk there in terms of a COVID perspective was very different.
Thank you. And are you aware as to whether there was any systems that were introduced or in place to alert teams or crews that were attending incidents as to whether there were cases of suspected or confirmed COVID-19?
Certainly during the first lockdown, none at all. There was, no testing, no vaccination. And patients did present in an asymptomatic way. It may be that people had just lost their sense of smell or taste. So, you had to weigh up that risk as someone got COVID, but they're not symptomatic. And it very much focused on the symptomatic cases. And in that first lockdown, people were gravely ill. Our profession saw patients in a volume of being profoundly unwell that we had not experienced before.
We're going to come back to the topic of risk assessments in a moment, but just staying on the topic of the guidance. So you've described how there was the one-size-fits-all approach taken to the guidance. Was the college consulted at all in the process of the guidance being developed, either in the early stages of the pandemic or later on?
No.
And do you think it would have been useful if it had been?
I think so, and I don't wish to diminish the ambulance representative's role in being on the cell, but it felt like a big echo chamber, and what our members were telling us in huge volume is that it didn't feel right on the ground. It didn't feel right to be in front of a patient who was seriously unwell and be less than a metre from them at all times, having to provide care and treatment to that patient without discrimination. And that felt completely incongruous to what was being sort of fed down the chain from the IPC cell, in that there was no evidence to say there was any risk, but in clinical practice it feels much more in line with common sense to say, let's support you to make your own decision about what the risk is until there's further evidence. And that's all we've ever asked for is can we take a precautionary approach until such time as evidence is around that says, either confirms that or says otherwise.
Thank you. And the first time that you asked for that, I think if I'm right in saying, was around the 20th of March 2020, when the college raised their concerns with the Health Secretary, Matt Hancock, at the time, highlighting the PPE shortage on the ground, asking for a review of the unique environment in which ambulance workers were working in, and for, as you say, that precautionary approach to be taken. Was there a response to that request?
No, and I would caveat that. I recognise that the government are in a stage where they're having to do a lot of preparation, but it's a very unique environment, and those patients that were being conveyed and treated by the ambulance crews and the paramedics were then going through ED into ICU or ITU, and they'd been sitting in the back of an ambulance for some time already. So we were trying to convey that it's the start of the chain, and you want ambulance workers and paramedics to be in work, not to be off work sick, so that they can keep this whole kind of patient flow piece going and give the very best care to the patients that they can. So disappointing we didn't get a response, but I guess at the very beginning of a novel virus. Did I expect anything else? Probably not.
And it's right, isn't it, that shortly after that, the recommendations for the level of PPE that ambulance workers should wear was published by Public Health England, and that was for them to wear a surgical mask, or FRSM mask, apron and gloves, unless they were undertaking an aerosol generating procedure or an AGP, in which case it was an FFP3 respirator mask that they were advised to wear. Can you just describe to us what the response was to that guidance from your members on the ground?
It was horror, actually. So the aprons were completely inappropriate for the environment that paramedics and ambulance clinicians work in. You may appreciate they're going in and out of a patient's house potentially to get kit or to take a patient. And the minute you went outside, the gown blew up in your face. And, our members felt that was inappropriate. One member actually said to me, they seem to have better protective equipment on the repair shop than they do in our own workforce. And it felt just so incongruous to them. They were looking at the guidance as well. They're healthcare professionals. They're able to research themselves. And they felt the words they used were cannon fodder and canaries in a coal mine.
And I think you've used the example of aprons in your statement as an area where the college actually raised those concerns. Were the correct type of aprons or suitable aprons provided?
No. The move was to go to gowns, which we felt was much more appropriate. We know that there were issues with the supply of the respiratory protective equipment, and we know that not all the suits and the gowns were able to fit the ambulance staff themselves. You were very, very small or very, very large. The gowns didn't fit, so you had to revert to an apron. And many members told us they were buying their own protective equipment from a very large online retailer.
Thank you. And can you recall when there was a move towards gowns being issued?
I think it was quite soon after people realised the aprons were a terrible idea, and people needed to cover their uniform, but I can't remember the exact date.
That's no problem. Continuing on the topic of supply, in your statement, you've described how the IPC PPE guidance for ambulance workers differed to other high-risk environments, and give the example of ICU or A&E or ED, and that you'd heard reports of ambulance staff having to don and doff or take on, take off PPE in order to put on the RPE, in order to hand over the patient in the hospital. As far as you're aware, what impact did that have on not only patient care and treatment, but did it impact on supplies at all?
Yes, well, the supply issue was very inconsistent. So you may have, I think you've heard already an inquiry about this sort of push stock, this stock that comes through the supply chain. And my current chief operating officer was in a very senior manager in the ambulance service during COVID, and he describes sort of 4 or 5 times a day there would be guidance changes and telephone calls about you've got 2 pallets of respiratory protective equipment coming in for one organisation. Where is the most need? So trying to coordinate that. Sometimes the stock was then quarantined because it was the incorrect stock or out of date. So it was, for those people that were trying to negotiate the logistics of all of that, it was a real nightmare for them, I think, in terms of trying to protect the staff with sometimes very little respiratory protective equipment, or not knowing when the next batch would come in.
And were there factors that are unique to the ambulance environment, again, that make the distribution of PPE stock, when it's kind of unpredictable, more difficult than, let's say, a hospital where you've got one big building? Obviously, with ambulance, you have many different stations. So did that make it any more difficult?
It did, and it's a very remote workforce. So, you know, there wasn't an opportunity for the staff to always come back to their base station to replenish their respiratory protective equipment. There was very little acknowledgement of that maybe people needed to take enough stock with them and then flag to the control centre when they perhaps needed to go back to station to pick up more equipment. And parallel to that, there were people who were with patients for hours on end in an ambulance outside ED where they were wearing the same protective equipment. And the Association of Ambulance Chief Executives had a proposal that the crew rotate around so that they minimised the risk. But in many EDs, the staff were not allowed in because the staff didn't know whether the patient was COVID positive, and therefore paramedics and ambulance clinicians coming into the ED were stopped. So they couldn't, there was no soap and water in an ambulance. You can't wash your hands, you can't take off your PPE and dispose of it easily, you can't eat or drink or go to the toilet. So it's just a very unique environment, and the distribution of respiratory protective equipment, linking in all those factors, is quite a logistical nightmare.
Staying on the topic of IPC guidance, you have said in your statement, and indeed raised this as an issue throughout the pandemic, I understand, that the hierarchy of controls which the sector were encouraged to follow was not in fact suitable for the ambulance environment you've described. Can you explain why that was the college's view and what response it received when it raised those kind of concerns?
You're at the very base of the triangle, really. You're on the last two sections, the administration controls and the PPE. You can't eliminate the hazard, you know, and so the ability for those working in the ambulance sector to have any effect from the hierarchy of controls is really around lateral flow testing for administration controls, or donning and doffing training, and then you're left with PPE, which is the last resort, and even that wasn't adequate. So it felt a complete misnomer in terms of how the hierarchy of controls were almost being sort of reinforced to the college, certainly, and ACE were doing that as well. And we spoke with the IPC representative and said it makes no sense that we're at the bottom end of this hierarchy and all the crews are just being told to wash more surfaces and make sure that they're compliant with their IPC practice, which they were, and it felt a bit disingenuous to say that that was the only thing they could do to mitigate their risk of infection.
Thank you. I want to take you to a document now, which is an example from an ambulance service of the local guidance on risk assessments. This is INQ 300332. Thank you. And this is page 4. And that is behind tab 14, if that helps you to have it in front of you as well. This was the risk assessment that was in place in February 2020. If we look at down on the left, from risk of infection to ambulance staff, states there that it can still occur within 1 to 2 metres of a patient with impossible of confirmed COVID-19. However, the evidence and guidance from the World Health Organization and Public Health England is that a different level of PPE is required. And then on the right, it says that staff are encouraged to continue to carry out dynamic risk assessment in relation to PPE that was used. I have a couple of questions about this document for you. First of all, in regard to the apparent contradiction highlighted first of all, that obviously echoes a lot of what you've been saying around the difficulties with maintaining social distance from a patient in the ambulance setting. What kind of concerns or problems was that causing for paramedics on the ground with that apparent contradiction?
created such anxiety and fear. So one of my team, who was also supporting South East Coast Ambulance Service, had said that she was, because she didn't feel protected when she went home, in full sight of her neighbours, she would strip off in the garden before she stepped in her house because she was so frightened that this protection was inadequate. So, you know, you make light of it a little bit to say, well, you know, your neighbours must have had a terrible shock. But literally, who strips off in their garden to save their family? That's the sort of level of anxiety we were talking about. People were hiring shepherd's huts to live in so they didn't have to go back to their family because they didn't feel protected.
And moving then to the guidance on dynamic risk assessment in relation to the PPE used, that's a phrase that we will see that comes up quite a few times. And was there any guidance for paramedics that you were aware of as to how to conduct a dynamic risk assessment in the context of COVID-19?
No, I think as I explained before, the phrase dynamic risk assessment probably means something a little different to people who work for the ambulance sector, in that they're looking at something very different, you know, dangers and hazards and things of that nature. I'm not aware that anyone had specific training on risk assessments for COVID-19 specifically. They didn't feel like there was the time or the resource to be able to do that. But we did know that the Royal College of Nursing produced some risk assessments, which was just a template for how to conduct a risk assessment, much of it being about your own competence and about the controls you can exert. So we were just grateful that that had happened so that people could access it. But despite mentioning it to the Association of Ambulance Chief Executives, I'm not sure it was signposted other than by us. And what I would say, Ms Hands, is while this was going on, we had our paramedic members are not just those on the front line, they're senior managers, they're executive directors. And we heard the phrase of, we know this is what the guidance says, but we're going under the radar, which felt very, very difficult for them because they clearly were told to adhere to the guidance, and that was the national agreement. But some of them were doing something different because they just felt it wasn't right. And that phrase under the radar just seems that they were in a very difficult place.
Thank you. At the bottom of the document that's on the screen, page 4, it comes on to the topic of fit testing. And it says that FFP3 masks must only be used by staff who have been fit tested for the masks they're using. And staff must complete a fit check every time they are required to wear one. That just goes on to page 5. Can you describe for us how practical it was for a paramedic that is attending an incident to carry out a fit test when they identify that an FFP3 mask is required in order for them to respond?
So the fit testing would normally be done in a controlled environment, as I think Professor Shin may have said last week. It wasn't the perfume being held; it was in a sort of a tented environment where you would measure the particles and make sure that the mask fit correctly. And the ambulance service, because it has dealt with MERS cases, SARS-1 cases, etc., fit testing was not new to the ambulance sector, and it had been certainly something in my previous role that we used as a sort of compliance figure for our staff. So each of the areas would come to an accountability meeting, and we'd ask how they're getting on with their fit testing for staff, because it was inevitable that the pandemic flu planning might elicit, the fact that we were over 100 years since the last flu pandemic. So we wanted to be prepared in that sense. So the fit testing was difficult, took specialised people to do the fit test. The fit checking was making sure that the mask had the integrity and then that it was seated well on the crew member. And if you were working with another crew member, you could check the seal for each other in that sense. But with that rolling stock issue that I was talking about, sometimes you would get a completely different FFP3 mask that no one had been fit tested for. So we know that some ambulance services, West Midlands, South East Coast and latterly London Ambulance Service, went for the powered respiratory hoods because it negated the need for fit testing, still needed the good control and good fit of the powered hood, but that negated the fact they needed to be fit testing their staff.
Thank you. And were you aware of any? You've mentioned obviously there were shortages in the type of mask or the brand of the mask that would be provided wouldn't necessarily be consistent. Were you aware of there being any issues with alternative options made available, and whether that had any impact on members from a black ethnic minority background?
Certainly. So not everyone passes a fit test. Women tend to have smaller facial anatomy, and we know staff from ethnic minority backgrounds didn't always pass through a fit test. Sometimes, and I think certainly those 3 ambulance services I've mentioned provided mitigation by powered respiratory hoods. In some cases, our members from ethnic backgrounds said that they had failed a fit test but were given no alternative.
Thank you. Dealing briefly with guidance for non-emergency patient transport services, which you mentioned that the college also represents. It's right, isn't it, that there wasn't any national guidance forthcoming for those services until September 2020. So did the college play any role in advocating for the needs of that part of the sector? And are you able to provide any examples of the unique challenges that they faced that were perhaps slightly different?
Is this the patient transport, as in taking the patients for their dialysis treatment? And
Indeed,
yeah.
and COVID patients as well during the pandemic.
Yeah, so we didn't have a key part to play in that, although we had raised it in our discussions about patient transport staff as well. What we heard was that in the emergency ambulance there was some ventilation. I haven't seen the evidence, but we know that the national specification says that the ventilation will work a certain amount of times per hour, despite the fact that the plume will pull past the patient and the attendant as it's going into the vent, and there's no HEPA filter. We know for patient transport service vehicles there is no extractor. There is no national specification for those services, and we knew that where the patient transport staff were conveying more than one patient at a time, that they were less than 1 metre apart often, and that whole risk assessment, I'm not aware there was any risk assessment done for our PTS staff until very, very late, and we did lose PTS staff to COVID.
And just to confirm, they were at points during the pandemic conveying COVID-19 confirmed or suspected patients as well?
Yeah.
In other non-clinical settings, you've discussed briefly the guidance around ambulance cabs. I also just want to ask you about other non-clinical areas. For example, ambulance staff rest areas or the ambulance emergency control rooms, and whether you were aware of IPC measures being implemented in those spaces and any barriers or difficulties that they had with following or implementing such measures.
I think they tried. They certainly in the control centres they were putting up plastic screens, but again, if we suspect the transmission is other than droplet, it would make very little difference. We know a lot of our control room staff were off sick with the virus. The crew rooms depends on the estate of the station itself, so some are very small. Larger ones, it was a little easier, but certainly from December 2020, crews were lucky to get in a restroom at all. They were out all the time in the back of the ambulance at ED or going to 999 calls.
And it's right, isn't it, that there wasn't any national guidance from the public health bodies or NHS England or government for those areas, and so the AACE actually produced guidance known as the Working Safely Guidance that went through many iterations during the pandemic. Is that right?
As far as I'm aware, they didn't involve us in that. That was their development.
Okay, that was my next question. Thank you. I want to, you brought me neatly onto winter 2020 into 2021, December, and I want to take you through some of the correspondence that the college had with the government and ministers at that time, raising some of the concerns that we've been discussing. And this is set out at paragraphs 47 to 51, if that helps you through your statement. If we could start with a document INQ 30257-964, and it's page 3, it's tab 17 of your bundle. This is internal email correspondence between colleagues at Public Health England, but referring to a meeting that they'd had with the college and with AACE as well. And as you can see, this is dated the 11th of January 2021. And they talk about the concerns that yourselves and AACE had raised in light of the increased handover delays, that the ambulance sector was experiencing 10 to 15% staff sickness, and that the college was requesting flexibility for staff to be able to undertake a dynamic risk assessment that we've been discussing to determine the level of PPE they think is needed, and asking for guidance on handovers, and also asking for enhanced PPE. And then in the penultimate paragraph, this is the email says this is placing pressure on the frontline workforce and the call centre staff, part of the critical infrastructure of the ambulance services. These two issues alone have and will develop critical points in the patient care continuum. It reiterates that ambulance staff are maintaining professional IPC behaviours and responsibilities, but guidance for long delays and crew activity during these long waits, plus advice on enhanced PPE to safeguard against increased time spent would be, in close contact, with COVID-positive individuals would be helpful. Is that an accurate summary of what was discussed during the call with Public Health England, as far as you can recall?
It was partly. So much of it was around the fact that surely no healthcare system wants to render its emergency services useless by not having the amount of staff required to do what they need to do. So we presume this was on the back of the letter we had sent, and it was interesting. We felt that ACE had also had concerns, even though they were telling us they were happy with the guidance, they were compliant with the guidance. But this sort of speaks to something else. But we certainly felt that if this issue remained unaddressed, that the ambulance delays would worsen, in that there were no additional staff to go to patients in the community or even deal with them through the telephone system, through triage with clinicians in the call centre. If you reduce your workforce through sickness, you don't have enough to do what you need to do. Some Churchill quote that one of our members said about, it's not good enough to do your best, you have to do what's necessary to succeed. And that's very much what we were trying to put across to PHE in that call.
Thank you. And if we go up to page 2, we can see the response to that email. In summary, the Public Health England response set out there is that there would be no changes to the PPE guidance or any additional guidance issued. And they reiterated the need to double down on the existing IPC guidelines and local systems, and to carry out dynamic risk assessments adopting the hierarchy of controls. And we don't need it on the screen, but we can see from email correspondence from the AAC representative who attended the UK IPC cell on behalf of the sector, showing that was discussed. Essentially, that is a summary of what was discussed at the UK IPC cell in January 2021. Was the college satisfied with that response and the suggested approach? And would it provide the protection and reassurance that the college's members were seeking at the time?
Nothing could be further from the truth on that. No, we were completely unsatisfied. And for us, it just felt, again, that there was this sort of reticence to understand the very unique nature of the work. You know, someone just needed to apply some common sense. Go in the back of an ambulance and have a look yourself and see the space in there, see what the crews are dealing with just when they're in the ambulance, let alone going into patients' homes and environments where the risk is unknown a lot of the time. So it just felt completely incongruous.
And that point of going into the back of an ambulance, obviously this is at the time of the peak of the second wave of COVID-19, but also the middle of the winter. Did those factors impact the ability of those in the back of an ambulance to carry out these kind of, to implement these kind of measures?
Absolutely. Most ambulances don't have a window to open. So that again was something that had been failed to be recognised by anybody. And to open the back door of an ambulance when the temperatures were down to around -2 with someone who may be frail and elderly, who is profoundly unwell, was simply not acceptable.
Thank you. If we move on to the next document, which is INQ 30257-965, and that's at tab 13 of your bundle. This is a statement put out by the AACE following the advice that they'd received, or you'd received from Public Health England. If we go to the bottom of that document, again, we can see here this reference to the importance of carrying out a individual dynamic risk assessment with consideration of the transmission route and PPE guidance, and reiterating that there's no evidence that increasing the level of PPE in non-AGP scenarios would provide any additional protection. At this point, was there any guidance or support available to those carrying out an individual dynamic risk assessment on the front line as to the how to consider the transmission route of the virus and the PPE guidance, and how that should feed into their risk assessment during COVID-19?
Other than if they'd done one themselves, no. So you know, we talk about the AGPs and the non-AGPs. You know, people with COVID cough and splutter and have, you know, had high temperatures and, you know, you don't sit in the back of an ambulance for 10 hours and not speak to your patient. So all of these were non-AGPs, but, you know, the paramedics and ambulance clinicians were equally concerned about that as well. So if people have difficulty in breathing, you might do something called nebulization, which is where you put some medication in a port and it's driven by oxygen and that comes out. And you know, it's really difficult. They can reinforce this as much as they like and did reinforce it over and over again. It didn't satisfy the workforce, and we will have a generation of workforce who feel undervalued and not listened to. But also it didn't stop the ambulance crews getting COVID and you know, those poor patients, in terms of being in that environment as well, you know, it just there was no common sense.
Just for, sorry to interrupt.
Yes, not at all.
Just for going, do I take it from the words in blue at the bottom? This should be based upon the individual's dynamic risk assessment with consideration of the transmission route. That the individual paramedic was meant to assess the transmission route?
Yeah, exactly. And most paramedics felt it was airborne. My lady.
Sorry to interrupt.
Not at all, thank you. Is the college aware of any occasions where an individual risk assessment would lead to the paramedic deciding that a higher level of PPE would be appropriate in the circumstances, and whether that was always available to them at that point in time?
Sometimes they did, you know, when situations availed themselves and people felt very vulnerable, they would use a higher level of respiratory protective equipment. And a couple of things happened. So in some areas, the respiratory protective equipment was locked away and needed a manager to access replacement RPE, at which point the crew or paramedic would have to explain why they'd used a higher level of RPE for a non-AGP procedure. In some cases, supplies were very short. We know certainly from our colleagues in Northern Ireland Ambulance Service that stock was very short there. And we couldn't ascertain whether the management response to that was because they were worried that the supplies were short and they needed to hang on to some, or whether they were reinforcing the guidance. And our members couldn't tell us either, other than the fact that, you know, if you had used RPE on a night shift, for example, there was no manager there to unlock the cupboard. So that's why people ended up buying their own protection.
And if we take a practical example of being on the scene, attending to an incident, carrying out this risk assessment and identifying that a higher level was appropriate, was it always available in those circumstances? If, for example, as you're saying, it was locked away or they needed permission, what would happen in that moment in the scene?
Clinicians would either, you know, when you're faced with a patient, you're not going to deal with yourself, you're going to deal with the patient, and sometimes that put our members describe being put completely at risk and feeling very vulnerable, but they were trying to do the right thing for the patient. So sometimes they would expose themselves to a risk knowing it was exposing themselves to that risk, and sometimes they would just don the level of RPE that they had. You know, a face mask isn't PPE, but they would don that as some small form of protection and then worry about it for the rest of the shift.
So just finishing on that time period in 2020, winter 2021, there were no changes to the IPC guidance for the ambulance sector during that period, was there?
No.
No. Thank you. Moving forward to January 2022, there
Before
is...
you do that, sorry, Ms. Hans, would that be a convenient moment to stop there? Or would you rather deal with January? It's entirely up to you.
I have two questions, and then I think it will be a convenient time, my lady. Thank you. I will keep them brief. In January 2022, we see IPC guidance specifically relevant to the sector published by Public Health England, essentially saying that RPE should be available if a risk assessment indicates it would be appropriate, and that the assessment should include an evaluation of ventilation, and also requiring trusts to identify all staff that might be at risk of exposure to airborne particles, not just AGPs, if rigorous risk mitigations are not in place, and to provide access to FFP3 masks and training. So did that guidance go any way in addressing the concerns that frontline ambulance staff had felt during the pandemic and the period we've just been discussing?
To a degree, it's better late than never, but I think by that stage some of the staff just felt that there was, you know, there's little to celebrate with that at all, because the high risk had passed. Even though COVID is still here, we've got a new variant circling around now. So, you know, there is little confidence in the IPC guidance.
And perhaps that leads me to my last question, and that is that in February 2022, the college was a signatory to a letter to the Chief Medical Officer, Professor Whitty, setting out the inconsistencies in the public messaging on airborne transmission and COVID-19 guidance across the UK. From an ambulance perspective, what led to that letter being sent and the issues that were addressed therein, were they responded to at that point?
Because we had formed a part of the COVID Airborne Protection Alliance, as it was in 2021, that was a kind of consensus view amongst us that there were areas that were still not addressed by Public Health England, and we certainly co-signed that letter on that belief that actually the weight of professional bodies and unions behind that letter should make someone sit up and think maybe we need to look a little more closely at some of the unique environments like ambulance paramedics and speech and language therapists, for example. So, the response is, you know, Professor Whitty has always responded to us. He responded to us in the middle of a shift New Year's Eve one night when we'd asked him to. So I believe people were doing the best they could, but still nothing was addressed. And today, if a new variant comes in within the next month or so, we're still in the same position.
Thank you.
Can I just follow up? Sorry. Yes. Having said it, you're coming to the end. As far as the letter went to Professor Sir Chris Whitty, Chief Medical Officer for England. Did the letter go to the devolved nations? You've made reference, for example, earlier to Northern Ireland and the like. What about the other nations of the UK?
There'd certainly been previous correspondence, my lady, that had gone to all 4 nations, and the college had also sent around the Chief Allied Health Professions officers across the 4 nations as well. I'm not aware that letter did. I can certainly check though, my lady.
But the point is that even if the letter only went to the Chief Medical Officer for England, these are problems
Yes.
that were going around the UK.
Absolutely.
Yeah. Right, I shall return at 2:05.